LUNGevity is the nation's leading lung cancer nonprofit, and we are changing outcomes for people with lung cancer through research, education, and support. LUNGevity initiatives position us as thought leaders in the lung cancer advocacy community, providing programs and driving change for those with lung cancer today and in the future. Subscribe to the LUNGevity podcast today. The information you hear may be vital to your survivorship. I want to welcome everyone to the program today. Whether you're Zooming in live or accessing the replay, thank you for being here for this very important discussion. My name is Katie Brown, and I am the Vice President of Survivorship and Support with LUNGevity Foundation, and I am joined by Dr. Amy Moore, also with LUNGevity. Dr. Moore and I look forward to talking about the virus, vaccines, and generally addressing all of your questions. Please remember that this program is for support and informational purposes only. Please do not take anything you hear, read, or learn about today as medical advice, but please do take the information that you learned here today back to your doctor to further that conversation. And with that, I would like to get started by asking Dr. Moore to introduce herself to the folks that may not be familiar with who you are and your background and what you do with, at LUNGevity.
Sure. Well, hey, everybody. Happy Tuesday. I know some of you met me maybe through ILCSC this past weekend, but for those of you who don't know me, I recently joined the organization in April as their first ever Vice President of Global Engagement and Patient Partnerships. What that means is that we're trying to take all the amazing work that LUNGevity is doing and build global partnerships and collaborations to expand on our work around clinical trials transformation, biomarker testing, and precision medicine, and making sure that we look at everything through a lens of health equity and access and availability, all those good things. But my background is I'm a Ph.D. trained virologist. So before I ever entered the world of cancer research, I trained and studied viruses. So, the current situation, the pandemic and what it means for the lung cancer community is a convergence, we never anticipated. It's certainly one that we can't afford. And, for a year and a half now, I've been really trying to lead efforts to educate and empower our community with the information y'all need to make informed choices to stay safe and healthy. And so today I'm making myself available to answer all the questions. There's been a lot of new information coming out recently. And so we want to tackle all those things from FDA approval, boosters, so on and so forth, so that you feel like you have the information you need to make the right decisions for you and your family.
Yeah, and that's so important. And we are so lucky to have you at LUNGevity, and our patients are lucky to have your expertise. So with that said, I do want to mention that on our website, we have great resources about credible information about COVID-19. It's kept very up to date. So please visit our website, www.lungevity.org, to read more about that. But I do want to ask, and we don't have to go all the way to the very beginning, but I do want to ask, how is the virus / Delta variant, if it's different, how does it spread?
Okay. Well, so to take it a little bit back to the beginning, and then we'll fast forward to today, what we know is that COVID-19 is the disease that is caused by a virus called severe acute respiratory syndrome coronavirus 2. So that's a mouthful. SARS-CoV-2 is the virus that causes the disease, coronavirus disease, which is how it got its name, COVID, coronavirus disease. And it was first discovered in China in 2019. It is a respiratory virus, meaning that it enters your upper respiratory tract through your nose and then can move into your lungs and cause disease. So it is spread primarily by large droplets, and now we know that also aerosols. So as you sneeze, cough, you're dispersing those droplets. As you talk, you're expelling those droplets that can cause infection. Early on, there was a lot of concern that maybe the virus was transmitted by touching things, and so we were all, putting our groceries out in the garage and wiping down our packages and putting our cardboard boxes out in the garage. we know now, we have more information to say we don't really think it's being transmitted in that way. So it's primarily airborne respiratory droplets. So Delta is a variant of the virus. We talk about variants. So what that means is, with the original virus that we were dealing with in spring of 2020, it has changed over time. As viruses infect people and spread, they have the ability to change and adapt to the circumstances that they're in, because they're looking really to get a competitive advantage. What gives the virus itself the ability to continue to replicate or make more copies of itself and infect more people. And Delta first emerged in December of 2020 in India. And so, we remember the headlines that in India, there was, this huge kind of surge, and it was really dramatic and horrific. Well, now that variant has circled the world, and it accounts for over 90% of all the COVID infections here in the US. So it has overtaken the original strains because it has a competitive advantage that favors its survival. So what we know about Delta is that it's at least twice as contagious as the original strain of the virus. So we talk about something called the R0, or the reproduction number of the virus. That simply means how many people if you get sick, how many people are you going to turn around and make sick in turn? The original strain, it meant that you could infect maybe 2 to 3 other people. Now with Delta, that number ranges somewhere between 5 and maybe 9. So that means for every one person that's infected, 5 or 9 more people would get infected. So it's much more contagious. We also talk about people who are infected with Delta have higher amounts of virus. We talk about something called viral load. They have up to 1,000 times more virus in their nose, in their upper respiratory system than with the original strain. So it's concerning, to say the least. And that is partly the reason for why we see it spreading so easily, because it's just, it's much more contagious. So I'll pause there.
Yeah, and so that's why I think there is a lot of confusion and a lot of questions, especially with within our patient community, with the general public, but also with our patient community. So that takes me back to some of our initial questions that should we get vaccinated? Should we not get vaccinated? Should are lung cancer patients safe going in public if they're vaccinated? Let's talk about the vaccine. Before we go to Delta,
we'll back it up a little bit. What do we know about
today?
A little cha-cha. What do we know about the risk of to the lung cancer community with this virus? The data is clear now, a year and a half into this, that patients with lung cancer, and I would say cancer in general, are more susceptible to infection first and foremost. And that may be partly, we talk about the virus is able to enter cells that have a certain receptor coding them. And you may have heard something called ACE2, that's angiotensin converting enzyme 2. I'm going to throw out big words. But ACE2 is that door that allows the virus to enter your cells. Now, lung cancer, patients with lung cancer may, this is an area of investigation, have more amounts of that virus on their cells, which may allow the virus to infect you more easily. Now, once you're infected, what we also know is that patients with lung cancer have higher mortality rates. There are numerous publications that show that patients who are infected with SARS-CoV-2 have mortality rates ranging from the mid-20s to 40 or so percent. So the lung cancer community is especially vulnerable not only to infection, but to increased severity and mortality from the virus. So what that means is that vaccination is a crucial step in protecting our community. And what I can say is that, the data indicates that vaccination is safe for patients with lung cancer. And the good news is that in several studies now, including one conducted by Dr. Balazs Helmos and his colleagues at Montefiore Hospital in New York, they have reported that patients with solid tumors, which would include lung cancer, of course, by and large, mount strong antibody responses to vaccination. So that's very encouraging. And that's regardless of type of therapy that you may be on. So that gives us some encouragement that by and large, the majority of patients with lung cancer are able to mount an effective response. But certainly what we know is that a subset don't. And so as you've heard recently, the CDC and the FDA have recently come out first recommending that patients who are immunocompromised get a booster shot. And we can delve into some of the more, some of the latest guidance, including as of yesterday, recommendations and guidance from NCCN regarding boosters, who should get them, kind of the timing of that. So let me pause there and see if you have a follow-on question before we get into more of the nuances of boosters and what that means. But let me be clear in saying that vaccination is indicated for patients with lung cancer, and by and large, it doesn't matter what type of therapy you're on, if it's immunotherapy, if it's chemotherapy, if it's target therapy, undergoing radiation, undergoing surgery, you should get that vaccination whenever it's available. And I think what we're seeing is, a real consensus that you shouldn't delay getting vaccinated, especially in light of this most recent surge, which is particularly severe.
Absolutely.
But of course, talk to your doctor and your own, care team about the details of your particular situation.
Absolutely. So to piggyback, and the chat is blowing up. Back on the importance of vaccines. Let's talk a little bit about vaccines before we go into the variant and into Delta.
Okay.
Will getting vaccinated make your cancer treatment less effective? Is that something we know yet?
There's no evidence to say that vaccination will interfere with your treatment whatsoever. So we're doing, there are multiple studies underway. And one thing I want to convey to this community, because I think it's partly reassuring, is that because of the convergence of lung cancer and COVID and the potential implications for this community, in spring of 2020, last year, several of the giants in lung cancer research and clinical care, Drs. Fred Hirsch at Mount Sinai, Dr. Paul Bunn at the University of Colorado, Dr. John Minna at UT Southwestern, they convened what they call the COVID Lung Cancer Consortium, which is really a gathering. We were meeting kind of every other week. We went on summer hiatus, but a convening of the leading lung cancer experts, thoracic oncologists, to really bring their collective expertise and knowledge to bear on the intersection of these two diseases, what it means for our community. And what it has materialized in is a specific study that's being led by Dr. Hirsch, as well as Dr. Adolfo Garcia Sastre, who's a member of the National Academy of Sciences, a world-renowned expert in respiratory viruses. And we're looking to, and I'm part of it, I'm part of the steering committee for that grant. We're studying antibody responses to COVID-19 in patients with lung cancer specifically. So it was designed to ask these very questions, are there any interactions between, first of all, we were going to look at vaccinated versus unvaccinated. The good news is that the majority of patients are now getting vaccinated. So it's quickly kind of morphed into understanding, issues related to vaccination and therapy. So we will be, as more patients get on the study, be breaking it down by, type of therapy, if it's immunotherapy, chemotherapy, targeted therapy. But what we're going to present even at the upcoming World Lung Conference here starting next week is some early data on 111 patients with lung cancer. And what we find is that the majority of the ones in our study have mounted effective antibody responses, yet there's that subset that don't. So we're working to understand the reasons for that. Are there any commonalities that may explain it? Thus far, we don't see them. All that to say, there's a lot of effort underway to understand, kind of the long-term implications of the pandemic, of vaccination. specifically on the lung cancer community. And I think I drifted kind of beyond your question. I hope that I somehow addressed parts of it there, but
you absolutely did. And I think the one of the most valuable takeaways from that is that there are experts like you studying this and working on this and convening regularly so that you guys have the most up-to-date information.
Absolutely. Yeah. I mean, I think that's something that, you know, I take great comfort in, you know, that here all these leading world experts understand the gravity of the situation, and they have, you know, dedicated themselves to being part of this effort to understand what it means for the lung cancer community.
Absolutely. Absolutely. That's fabulous. Will the vaccine activate your autoimmune disease? And on the flip side, does being immunocompromised make the vaccine less effective? So I kind of squished.
Let's start with the second, then we'll come back to the first. So, you know, the issue of being immunocompromised is a serious issue, and it's so much so that we know, based on the data that we have in hand a year and a half into this, that patients who are immunocompromised, either because of, you know, active cancer treatment, or because they've undergone a stem cell transplant, or they've had an organ transplant, they're on, you know, immunosuppressive regimens because of a transplant situation, or maybe they have HIV. There are several kind of defined categories where the CDC and the FDA came out and said, if you fall in these categories, we recommend that you go out and get a booster, because early studies have shown that the response to vaccination is not as good in those individuals. So it's not as high as we would like it to be. Now, a lot of people get kind of fixated on, you know, antibodies as the be all end all kind of indication of, do I have immunity or not? Am I protected or not? And there's some caveats to that I want to address from a scientific standpoint, at least. Now, you know, when we talk about our immune responses, our immune system is a very complex, elegant system, you know, and we have what we call B cells. Those are the cells that make those antibodies that we're also excited about and interested in. We have T cells. T cells can also fight viruses. And what we know is that our immune response is going to be a combination of those two things. So, you know, some people ask, well, you know, do I need to go get my antibody level tested to know whether or not I'm, one, protected, or two, I might need a booster? I would say at this point, both the CDC and the FDA are advising against going out and getting those antibody tests, but it's an area of active investigation. So, you know, something that we're looking at through this project that I described with Mount Sinai is to say, you know, do we need to follow lung cancer patients? Because again, there's a subset that seem to not have as good a response as others. Do we need to maybe start measuring their titers, which is a fancy word for levels of antibodies? And for those where we see low level, maybe we give them a booster at that time. So it's an active area of investigation. So, you know, the thing I want to impart to people is, you know, just because antibodies might be low, it doesn't mean you won't have this other piece of your immune system called T cell immunity that may play a role as well. There's also something called memory B cells. So your immune system is so smart, you know, it sees a virus and then it remembers that, oh my gosh, you know, I've seen this before. And if it sees something like that again, either a reinfection or something, a virus that maybe looks similar in the future, you know, those soldiers come marching back and they start churning out those antibodies again. So, you know, it's pretty cool, you know, if you want to geek out on the science front. I think it's encouraging as well. Now, let's go back to the autoimmune question, because I think that was the first one. So, you know, there's concern. People say, well, if I, you know, I have an autoimmune condition, or, you know, will the vaccine activate my disorder? You know, I think it's encouraging, and I would say, like, is it the Lupus Foundation? I think I shared with you a link earlier. They share some great information on their website. And so by and large, if you have autoimmune disorders, you are not what we say contraindicated for vaccination, meaning you are able to go get vaccinated. You shouldn't be concerned about getting vaccinated if you have an autoimmune disorder like lupus. You know, again, I'm speaking in generalities. You know, I do want you to keep that in mind, that for the most part, that's not a reason not to get vaccinated, but I don't know the details of all of your individual cases and your personal history. So I want you to have those conversations with your care team. But by and large, vaccination is safe, even if you have autoimmune disorders like lupus. Now, I think, Katie, you and I were also talking about, what about if you have a clotting disorder? I know that's come up because some people have heard, about the J&J vaccine, and although it's not used here in the US, the AstraZeneca vaccine, having this rare blood clotting issue that arose in some patients with the J&J vaccine. I think it was like 6 patients out of 6 million doses delivered, extremely rare. It's something called what is it? I forget the acronym, but it's a form of thrombocytopenia, meaning there are platelets involved in forming these clots. And it can manifest in a really short time frame after the J&J vaccine. So we're talking days, if not a couple of weeks, not like months later. I mean, very short term, but like the most severe headache you've probably ever had in your life, or you could get an abdominal blood clot. Even so, the CDC and the FDA said it's not a high enough risk to take that vaccine away. So it's still being used under the emergency use authorization. So even if you have a genetic clotting disorder, I think we were talking about like factor V Leiden or some of the other ones that are out there. And I even have some family members with an autoimmune clotting disorder who got vaccinated, totally fine, no issues. I would say in the case, if you have a clotting disorder, you want to probably lean toward one of the mRNA-based vaccines, so either Pfizer or Moderna, instead of J&J or AstraZeneca, just given that very rare kind of manifestation of clotting disorders or clotting adverse events in that situation. So that's autoimmune diseases. By and large, you are good to go to get vaccinated.
Perfect. And it's been on Dana's mind too. Will the vaccine affect fertility? That's a big one that a lot of folks in that, the childbearing years are asking us in our meetups.
Yeah, I hear this one a lot, and I can say the good news is no, it will not affect fertility. In fact, it is critically important that women who are pregnant or breastfeeding, that they get vaccinated. And what we know is that, unfortunately, there's a growing number of cases of women who are pregnant who are miscarrying, who are having to deliver their babies very early, in some cases too early for them to survive. Cases where the moms are dying and losing their babies from the infection itself, not from vaccination. COVID disease is the greatest risk to pregnant women and their babies. The good news also is that if you're pregnant or breastfeeding, that if you get vaccinated, you're superwoman now. You may be able to transfer those antibodies across the placenta to your baby, through your breast milk to your baby, and that's going to protect your baby for at least a couple of months. And so vaccination is the best way to ensure a happy and healthy start for women who are pregnant and their babies. Now, the point of fertility, this is something that is, again, a lot of misinformation that's out there, a lot of confusion, and we don't fault people who aren't scientists for being confused. I mean, it's hard for scientists to keep up with the information. It's coming rapid fire. We're learning in real time. So, this isn't a place of judgment. This is a place of education. And I would say when it comes to fertility, there's no evidence that vaccination impacts fertility. I have a 12-year-old daughter. She has been vaccinated. I put my money where my mouth is, So I think the reason there was some confusion that there were similarities between the placental protein and between the spike protein, but that's been debunked. There's no evidence that the mRNA vaccines can impact fertility at all.
That's so good to know. I've heard that question so many times, just myself. It's a lot of misinformation out there.
It's confusing, and I understand that. And it's the reality of where we are, and we have to navigate it in a way that's sensitive and, that meets people where they are, and tries to educate them in a way that, that they feel they're talking to somebody who's trustworthy and relatable and accessible. And that's a role I've been trying to play now for a year and a half. And many of you follow me on social media, you know that I'm very passionate about trying to educate, empower, inform the public to make good choices, because I just want y'all to be safe. I want you to be around so that we can continue to fight lung cancer, so we can continue to enjoy life, so we can get back to normal. And I'm doing everything in my power to make those things happen.
You are, and thank you. I think yeah, people are starved for information, and Ed in the chat says that people are starved for information and will believe almost anything that they read. So I guess this is a question from me. Why is there so much misinformation? Is there some kind of conspiracy out there that is trying to keep information from patients? And what do you suggest patients do to find credible information so that they can make the best decisions for themselves?
I think the why is a hard question, and maybe something that's beyond the scope of this conversation today. But it is the reality we find ourselves in. And so, what I've tried to do, and my colleagues within LUNGevity and across the different lung cancer advocacy organizations, we came out of the gate swinging last spring, and we started pushing out, coordinated joint updates to the lung cancer community, because we realized, one, in those early days, there was a void of information. So we were trying to curate and provide scientifically vetted information to our community so that they can make informed decisions. And obviously in the year and a half since, there are other organizations and resources that have kind of filled that void. So, in terms of what would I consider to be reliable sources, I think, certainly we try to convey current information. I would say, the various cancer centers nationally, they often have COVID pages. I would say CDC is a reputable, I know people will debate that, it's a reputable source of information. Your local health departments are a reputable source of information. So, find those sources that you can trust. I would say stay away from, media, and things get, misconstrued, miscommunicated. I don't necessarily know, I choose to believe the best in people rather than the worst. And so that's the mantra I try to live by, is treating my neighbor as myself, and trying to give it to people straight. And I've tried to do that this whole time. And I feel like, the lung cancer community shares so much of themselves with us, and I'm trying to do the same so that people see me as someone they can relate to, not just a scientist, but as a person, as a mom, as a friend, as a daughter, as a sister. And, hopefully by doing that, they say, well, I don't understand all that, but I know Amy, and I can go to her and she will tell me what's real and what's not.
Absolutely. And that's the benefit of us having a Dr. Moore on LUNGevity staff. So we appreciate you, and we appreciate that. Back to the vaccines. So yep. If you have had COVID-19, should you still get vaccinated? Like, are you protected if you've already had COVID?
This is another area of confusion. And, there are some, I've had friends from back home that I grew up with, from like kindergarten, who said, well, my doctor told me, I already had COVID, so I don't need to go get, vaccinated. And I'm like, wrong. Because the reality is we don't know how long you will have some immunity for some period of time. We don't know how long that lasts. And so your best protection is to follow that up by getting vaccinated. So even if you've had COVID in the past, you should still go out and get vaccinated. And in fact, you may even, it will boost you enough that you're going to have added protection. And it's an ongoing area of investigation. I don't want people to take this as, Dr. Moore said, only one shot, but what we're finding, based on research, is that people who've had, COVID, even with a single shot, they may get, a nice response, but the recommendation is still that you get the full 2 courses if you're getting, the mRNA vaccine, so either Pfizer or Moderna. But, time may show us that if you've had COVID previously, that you may be okay with a single shot. But jury's still out there, but that's an area of scientific investigation.
So one of the questions in the chat is along those lines. I think I just, let me see. There he is. There it is, Dana. Getting back to the vaccines, can we over-vaccinate? Is that something that we need to worry about, being over-vaccinated?
I don't think that's a concern at this point. Anecdotally, I would say we're seeing the full spectrum of the hyper adopters of vaccination, and then of course the people who are a little more reluctant. And so there are some people who've kind of taken it on themselves to interpret the data that's available, and they say, okay, I'm not going to take my chances. I'm going to go out and get a booster now, and I'm just going to keep boosting. And we know that it's a little bit Wild West out there when it comes to implementation of the guidance around boosters. So people can kind of walk into the pharmacy and they may, fudge their vaccination history, or they may fudge, certain details, and they may be able to get access to a shot. Now, we need to manage expectations of what you're going to get if you do just keep getting, boosted and boosted and boosted. Now, we do think it's good, and we are recommending that patients who are immunocompromised, including those who are within, got their immunization within the past year, who are on active cancer therapy, they will likely want to go out and get their booster. And that's consistent with what the NCCN guidelines said as of yesterday. So, that's one thing. But I want to be clear that, even if we get boosted as patients with cancer, that doesn't mean now I can throw off my mask and I can go to Disney World and I can start doing all the things that I wasn't able to do before. Our community remains vulnerable. And that means that as long as we're seeing high levels of virus transmission across the country, that we need to continue to layer those precautions to stay safe. So the vaccines remain extraordinarily effective at preventing severe disease, at least a hospitalization and death, even against Delta. And I want to stress that, because people say, well, is the vaccine efficacy waning? We hear these news reports and it's waning and I need to go get a booster. And what does that mean? It is waning, but, against severe disease, hospitalization leading to death, the vaccines, even against Delta, remain roughly 90% effective, about 88%. Now, when we say they're waning, that means they're not as effective at preventing infection. That means you can still get the virus, and that's why we're seeing breakthrough infections. But I want to stress a point here that the vaccines themselves were never intended, expected to block infection entirely. They were designed to stop people from dying, point blank, and they have been more effective at that than we even dreamed would be possible. I mean, we were all kind of high-fiving when we saw how effective they were at blocking severe hospitalization or severe disease hospitalization and death. The icing on the cake with the original strain was that there was about a 9% reduction in infection. So what happens when you get a shot in your upper arm is you get antibodies called IgG kind of through, in your body, and that can help coat the virus and kind of signal that it needs to, be destroyed in a way, for simplicity's sake. Now, with the current vaccines, we're less effective at blocking the infection. So, later generation vaccines are going to tackle that and say, can we block infection? Can we block transmission? But I don't want people to perceive that the vaccines are failing now that, they're waning. They're still your greatest safeguard against severe disease, hospitalization, and death. And so remind me, what was the other part of that question? Because I get lost in my train of thought.
I was getting lost.
No wonder everybody else is lost. I get lost in my own head. How do I find my way out?
It was, it was all good. It was all good stuff. The fact that it was not made to block the infection, but that it was made to prevent death.
Severe disease and death. Yeah. And, we just got lucky, honestly, early on in that it did seem to block infection. And so that's the part that we see waning is, in that ability to block infection. So, but I did say, oh, can you overboost or can you over vaccinate? That was the original question. And so I would say, maybe not, but you need to realize that there's a limit in what you will be able to do, even with boosters. You need to continue to take those safeguards. I was telling a story online earlier. I got sucked into a TV show called like Homestead Rescue or something last night. I don't watch much TV, but it's a good analogy. So, it's this family who's living in the backcountry of California during the 2018 car fire that was so devastating. And their property was just a tinderbox, dry brush and dead trees. And they had twin 7-year-old girls. And honestly, they were too scared for their girls to live on the property. So they wanted this team to come in and help them get prepared in the case of a wildfire. So this team swoops in, they take out, all the dead trees, around 100 feet around the property, and they put in a sprinkler system, and they, make pens for the goats that are running wild so that if the time comes they have to evacuate, they can easily get their family, their animals, and get them to safety. And that's the way we need to think about this pandemic. There's a wildfire that's raging all around us, and it's moving closer every day. But there are things we can do to prepare and to safeguard ourselves. And we need to think of, instead of a house, the house is us in this context. So, when we wear our mask, we're protecting ourselves from the smoke, in this case, the virus. When we wash our hands, that's kind of our sprinkler system. When we, erect that 100 feet of clearing around the house, that's our social distancing, that's our vaccination. We're putting a perimeter around ourselves, around our families, and especially in the case of, I have a child under 12 who can't be vaccinated, just like these 7-year-old girls, it wasn't safe for them to be there. We're creating a zone of protection around our loved ones, whether it be kids who are too young to be vaccinated, around loved ones who are facing cancer, around those who are immunocompromised because of other conditions or can't be vaccinated because of those conditions. So we need to approach this as layering these multiple modalities of protection to give us our best chance at fighting back the flames. Now, yeah, you may say, I feel like I'll get lucky and the winds will blow the right way and it won't hit me, but it may. So, another analogy is the Swiss cheese model. And we talk about, with one slice of cheese, there are all these holes and things are going to get through. But as you start stacking slices, it's harder for things to get through the holes. So that's the way we need to approach the pandemic and the virus. Is we have obviously vaccination, but we have all these non-pharmaceutical interventions, masking, social distancing, washing hands, that when all that's combined, that gives us our greatest safeguard.
Right. And so concluding the actual vaccine portion of the Q&A, can you just talk a little bit about mRNA? Because we touched on it a little bit last time you and I spoke. Yep. I have a lot of patients who are concerned that maybe it's not the patient, but their family member, that getting vaccinated will alter their DNA, sort of in the same lines that, it might mess with their, autoimmune issues and other things. Can you talk about that a little bit?
Yep. So mRNA stands for messenger ribonucleic acid. And I know it sounds scary. It sounds like something that just, landed on Earth from a faraway planet. And it's, it's new, it's different. And what does it mean? And oh my God, it's got the worst nucleic acid in it. And that has to be bad, right? Like it's going to get in there and like turn us into zombies or turn us into who knows what. I want to reassure all of you listening that mRNA is a natural molecule that's in all of our cells right now, because we have DNA, that's the blueprint that makes us us, that's what codes for all the proteins and different things that make up your body. But DNA is really a set of instructions for making proteins, but it's in a weird language, so we have they're called bases. And it's, you know, if you've ever seen like the movie Gattaca, G's, A's, T's, and C's, it's a string of G's, A's, T's, and C's. And that language can't easily be turned into protein. So there's something that has to come and kind of be that translator, that intermediate that gets DNA into protein. And mRNA is what makes it happen. So mRNA can read those instructions and then put in a language that leads to formation of proteins. And that process happens every day in your cells. And you know, if we didn't have that, we wouldn't be alive, basically. So scientists said, hey, this is a cool way that maybe we can trick the immune system into thinking it's seen the virus without it actually having to see the virus. And I also want to reassure the listening, the viewers that, you know, long before mRNA vaccines were deployed against COVID, this technology was in development and already being tested against other viruses, such as flu, Zika virus, if you remember the babies that had like the small heads, and like Ebola virus, but it was also being tested against cancer. So there have been clinical trials underway testing mRNA vaccines against like melanoma. So there's about 2 decades of work that just happened to be locked and loaded and ready to deploy against COVID when it showed up in 2019. And that meant scientists had the tools ready, and all they had to do was figure out the message, you know, to code that spike protein. So that's what you see when you look at these cartoon representations of COVID, all these and just seeing this the virus for real, your body will be ready to respond. So mRNA is not going to change your DNA, tricking your immune system in a really cool way. And the other thing is, it's short-lived. So, you know, you get the instructions in the shot, your cells start turning out the spike proteins, your immune system, you know, starts revving up and making antibodies, and then they go away. Like, it doesn't become a permanent addition. It can't even, the mRNA itself can't get into the nucleus of the cell where your DNA is located. That just can't happen without a bunch of other enzymes and some other things to go along with it. It's scientifically impossible. So it's very safe, you know, millions upon millions of doses have been administered at this point. You know, the other thing is that people are concerned about, you know, well, what are the long-term effects? You know, with basically all vaccines studied in history, you know, if you're going to have an adverse event, it's usually going to be in a very short window following administration of the vaccine. You know, we don't see vaccines that cause long-term effects, you know, this far out. Now, of course, that's an area of active investigation. We're monitoring for that. But I would say the bar for approval of this vaccine has probably been one of the highest bars ever for any vaccine, because the stakes were so high. You know, this is a global population that we have to deliver these vaccines to. And because of that, you know, with the FDA approval of Pfizer's vaccine, for example, on August 23rd, you know, there's not much difference between the approval and the previous authorization, other than it means that all those individuals at FDA have come through literally over 300,000 pages of data. They have visited the facilities that make the vaccine. They're basically signing off on the process by which those vaccines are made. So every piece of the process by which those vaccines are produced has been, you know, people go and do site visits and make sure that it's all up to a certain standard. So it's an extraordinarily high bar to achieve. And I think good news is, you know, now we have that approval. I think Moderna is probably about a month behind. They filed for their FDA approval about a month after Pfizer did. I don't think that Johnson & Johnson has yet filed its paperwork for FDA approval, but, you know, they probably will in the near future. But mRNA is not going to change your DNA. You know, it's short term. It's not going to hang out in your body forever. yeah, so it's really cool technology that was in the right place at the right time. And aren't we lucky?
We are so lucky. And yeah, absolutely fascinating to know. And I repeated your words almost verbatim to somebody that mentioned this to me. So thank you for arming me with the, with the right information. So we've talked about COVID-19. We talked a little bit about like the vaccine itself. Let's talk about types of vaccines. Is there a vaccine is there a most effective or a more effective vaccine? Like, is it J&J? Is it Pfizer? Is it Moderna? And is that different when you look at it against the Delta variant?
So initially with the original strain that came out, all three vaccines were pretty comparable in terms of efficacy, especially against severe disease, hospitalization, and death. What we have seen more recently, especially against Delta, is that, the mRNA vaccines maybe are a little bit better than J&J, but, early on we said, take whatever vaccines available to you, especially in the days when they first rolled out and, it was hard for people to find doses and shots. We said, get whatever one you can get your hands on because it's still your best, protection. Now, I would say, the data suggests that a single dose of J&J or even the AstraZeneca vaccine seems to be somewhat less effective than 2 doses of either of the mRNA vaccines. And it's been enough of an issue that, people have said, well, for those who got the single shot of J&J, do they need to go out and get, a dose of one of the RNA vaccines? And in fact, a hospital out here in San Francisco started doing just that outside of any kind of official guidance. And so, that is not something that CDC and FDA have come out with official recommendations on. I think we'll be headed that direction at some point in the future for those who got J&J. You do have some protection, but I think, what we're seeing is that you probably have higher levels of protection with Pfizer or Moderna. And then there's a question about mixing. So, this played out like in Canada. We had some of our lung cancer patients who, they had their own challenge. First dose of AstraZeneca, but then they couldn't get a second dose because that's even though it's an adenovirus like J&J, so not mRNA, it's a different platform. They were like, can't get my hands on a second shot. What do I do? And so data coming out of Spain, Italy, out of Europe, where they did do some of these mixing studies, suggested that it was safe, so much so that Canada started allowing patients who got, a first dose of AstraZeneca to follow it with either a Pfizer or a Moderna. There are also questions about whether or not you can mix vaccines. So, what if you got, especially when it comes to boosters, I think too. So what if I got, my first 2 were Pfizer, my first 2 were Moderna, what do I do? The recommendation is to get your third dose of the same type. So, if you got Pfizer the first 2 times, then to get the third with Pfizer. But if that's not available, they say it's still okay for you to get a third shot with Moderna. Now with J&J, that's a special circumstance where there isn't an official recommendation yet. There are efforts, and J&J had come out with some data within the last couple of weeks, I think, that they looked at the second dose of J&J in patients and found that it gave a nice kind of boost to those patients' antibody levels. So more to come for J&J in the near future, I would say. People know that it's an area of intense scrutiny, and that those who did receive it may not be as protected as those who received the other vaccine types. But there's a question about what is the J&J vaccine. So you have 2 categories right now of vaccines that are kind of authorized or approved. So here in the US, we have Moderna and Pfizer. Of course, Pfizer just got FDA approval. Moderna is the other one that's under still the emergency use authorization. They are the 2 mRNA vaccines that I just described, kind of the technology. J&J and AstraZeneca use a different platform, and it's a virus that I actually studied from a PhD called adenovirus, where they've basically made the virus itself, it's more of a Trojan horse. It's just a delivery system to get the gene and cone spike, that spike protein from the coronavirus, into your cells, again, to trick them to make antibodies. But the adenovirus itself is what we call replication incompetent. That means the adenovirus that you're given cannot replicate or do anything in your body. It's just kind of a defective vector, Trojan horse, to sneak the gene and cone spike into your cells. So that's the big differentiator between J&J and AstraZeneca, and even the Russian Sputnik vaccine falls into that category. Now, there are lots of other types of vaccines that are in development, or maybe even that are beginning to be used in different parts of the world. We talk about DNA vaccines or protein subunit vaccines. And I would say, like, the New York Times has a nice tracker where you can kind of see all the different types of vaccines and where they are in terms of, are they phase 1, are they phase 2, are they phase 3, how are they progressing? So if you really want to get up to speed on all the different shots on goal that are out there, then I would encourage you to check out that New York Times tracker, and it kind of gives you the latest about what's going on, because we see there are limitations and we need to be prepared for, variants. So, we're crossing our fingers, and we've gotten lucky so far that the vaccines we currently have remain extremely effective, again, against the worst of the disease and the hospitalization and death. The challenge is that as long as the virus can continue to circulate among people, and that's what we're seeing now, is that, it's basically just a package of proteins and nucleic acid. It as I say, it doesn't care, where we're from or what our political affiliation is. It just wants those cells that have the receptors so it can enter in and make itself cozy and make more copies of itself and continue, spreading. As long as it can do that, it has the opportunity to continue to change. And, the additional adaptations it requires going forward, we may not be so lucky. Early on last year, our children seemed relatively safe from the virus, and we're seeing that in the face of Delta, that's starting to change. Unfortunately, we're seeing more hospitalization of younger adults, of adolescents, of children, and certainly for those under 12 who can't yet be vaccinated, that's of grave concern to this mom. I take off my scientist hat and I worry about my youngest and what it means. And I'm from the South. I grew up in a small town in upstate South Carolina, and I, have many friends and family who have made the decision not to get vaccinated. And it concerns me because as a scientist, I know what that means, not only for their health, but for the community at large. And so, I take this very seriously, but, it's because I come at it from a place of care, caring about people first and foremost and wanting them to be safe.
Absolutely. So let's talk about ways to stay safe. Okay.
Mm-hmm.
So we've talked about getting vaccinated. We've talked about the booster. So is there a recommendation for people who are immunocompromised and get the boost? Is there like a time limit, 4 months, 6 months, 8 months that people should wait?
Well, so what we're saying with people who are immunocompromised, I think you can get a booster as soon as kind of 4 weeks past your second dose. So if you got either Moderna or Pfizer, one's spaced out 3 weeks between the two doses, one's a month. But, if you fall in those buckets of who's considered immunocompromised, and I would say, based on NCCN guidelines released yesterday, patients with cancer, solid tumors, a year, on active treatment, they meet the criteria. So you can get it as soon as a month after your second shot. Now, we're seeing or expecting that sometime later in September, September 20th was the date thrown out by the administration, that boosters may become available to the general public. And I think, that they're saying it would be 8 months after you completed your second, dose. So for those people who were vaccinated early on, January, February, they're going to start becoming eligible, by September, 8 months in. So that's kind of the time window that we're talking about. That still has to be kind of green lighted by CDC and FDA. And I would say it's an area of debate among scientists whether or not the general public needs to be boosted at this time for the reasons I described previously. Like, it's not just about antibodies. You may have T-cell immunity working as well. But we'll see what happens and how that plays out. But what we're seeing right now is nationwide, there continues to be high levels of virus spread. So all the things that we did last year should be on the table once again. That includes wearing masks, that includes hand washing, that includes social distancing, avoiding crowds, especially in, I would say, areas where vaccination rates are low. And that means that you're just increasing your risk. So, there's no one size fits all communication that I can give to the listeners. I think, you need to evaluate all these things in the context of your own personal health situation, that of your family and those that you live with. In my case, I don't have cancer, but I do have a young child who's not yet eligible to be vaccinated. So even for me personally, it means I've started adjusting some behaviors. And, whereas early summer when cases were low, vaccination rates are high here in the Bay Area, maybe I felt a little more comfortable taking him to an indoor restaurant where there was, healthy spacing of people and whatnot. Now, I may reconsider some of those decisions. So I think you need to assess your own risk tolerance and that of your family, and have open communication with those in your circle to make sure that their behaviors mirror your own and that you have comfort with those you're around. And I would say, if you find yourself in a situation where you're among mixed company, that you definitely want to, practice those behaviors more vigorously, wearing your mask and whatnot. Hopefully, as we saw in India and in the UK, Delta will eventually, hopefully, come down. But we're now running into the fall and winter where people are once again going to be pushed indoors, which means we're going to see more spread. And with schools reopening, we're seeing more spread of the virus. So we need to be diligent. We need to be smart. We need to, make those choices for ourselves and our family that are going to keep us safe.
Absolutely. And back on the lines of safety, and I'm going to rapid fire these questions off my cell phone really quickly that have come in while we've been talking. There's nothing like last minute rapid fire Q&A, right?
Yeah.
Let's see. As a lung cancer patient, should I go to a provider that is not vaccinated?
Me personally, I would say no.
Okay. Do lung cancer patients have a right to ask if their provider is vaccinated?
Me personally, I would say yes. And I would if they didn't want to answer that question, I would not feel comfortable having them as my doctor. That's Amy Moore speaking. Again, you have to decide what you're comfortable with.
Yeah. And Katie agrees. Okay. Let's see. Limited information on the efficacy of cloth masks. Should they still be worn? Should only surgical or N95 be worn? And are face shields alone effective against airborne /viruses like COVID? That's a mouthful.
Yeah. So, I think there was an analysis, and I'd have to pull up the publication, but that compared different mask types. And obviously there's a gradient from N95 being kind of the best to, surgical masks, to cloth masks. They're, multi-layered, to gaiters being basically ineffective and almost as good as nothing. That was with the original strain. Now we've got Delta, which is at least 2 times as contagious. And so, I would think about the context of, where you find yourself. So, like, are you traveling? Are you on a plane or public transportation? You might want to lean toward an N95 or a KN95. I still routinely use the cloth ones myself. But if I was in a situation where there's high, rates of transmission, which is basically anywhere in the country, and low vaccination, and it was going to be crowded. I might double mask. I might combine a KN95 with, a cloth mask. I think we've overcome some of the, initially, they were in short supply. We didn't want to shortchange the healthcare workers because they needed them. I don't think we're as an acute a crisis anymore, but, there is different, I guess, strength of the mask. So, but I think gaiters, we can all agree, are really not that good.
They don't look that great either, just to be honest.
Well, some of them look cool, but they may not protect you, or more importantly, they may not infect or may not protect people around you. So,
right, absolutely, absolutely. So, I guess this is a follow-up to that. This would be absolutely great. But there was a question about how come you can only spread COVID to 6 or 8 people? Does that make any sense? How come it's not more? Like, how come you're not infecting more than just what happened?
Well, it doesn't. I mean, it doesn't mean once Amy's been to a big outdoor barbecue that only 6 or 8 people are going to get infected, and that's it. That she's maxed out. It just means we talk about kind of an average number of how many people you can infect. Now, if I go out today and I do a risky thing, I'm around a lot of people indoors, and I'm not vaccinated, then it's not like a one and done that you're only ever going to infect 6 to 8 people. It's just a way for us to assess how contagious a virus is. So, like the 1918 flu, which killed tens of millions of people around the world, it had a reproduction number of 1 to 2. Then we had SARS-CoV-2, the original strain, 2 to 3 people. Now we had Delta, 6 to 8 people. Chickenpox, 12 people. Measles, one of the most contagious, 18 people. So it's a way of us kind of arraying these different viruses on a spectrum of, how bad, how easily spread they are. And that helps us, really from a public health perspective as well, think about mitigation strategies, how to contain the virus, because the lower the number, the better off we are. And then in terms of looking at the reproduction number in a community, we want to get that number kind of below 1, because that means we have a chance of the virus extinguishing itself. When it's, as high as it is, it just allows, kind of for, unabated spread. So without a combination of vaccination and other kind of non-pharmaceutical interventions, we have an uphill battle.
Right. And then the plastic face shields that I see.
I mean, some people, are, they like all the different forms. And so you'll see the face shield, especially like maybe school teachers or different things, and a mask. I wouldn't necessarily do the face shield by itself. I've seen mixed opinions on that. I would still probably wear a mask, especially, because if it's open on the sides, given the increased contagiousness and transmissibility of, so we're making up words at this point, increased spread of Delta, I think you would want to kind of combine a mask with a shield.
Okay. And then there was a question about traveling. So if people are vaccinated and they make the decision to travel, what is the best way for them to stay safe on the planes?
So I realize, sometimes people have to travel, and sometimes, they want to travel, and people are tired of being cooped up for a year and a half, and they say, okay, I'm vaccinated, I'm willing to take the risk. I would say there's still risk, even if you're vaccinated. So, you might, depending on, again, your situation and where you're going and those kinds of things, you might want to consider, kind of limiting your activity pre-travel, kind of staying in a little bit more. You might want to consider testing before you travel. You might want to consider, I would certainly advise, depending on where you're going, again, testing upon your return. And so there are, both rapid tests available now, which is looking for what's called the antigen or for the protein. That's kind of a quick detection. There are kits, you can do it at home. You get results in 15 minutes. That used in combination with the more traditional PCR nasal swab test, can give you some reassurance when you return that you haven't, been accidentally exposed. And that's important, even if, you get a breakthrough infection, you're probably going to have mild, maybe even be asymptomatic. But again, if you have people in your household who, have cancer, or you have young kids who haven't been vaccinated, you don't want to spread it, and that's the other thing, that we know about breakthrough infection is that even vaccinated people may be able to spread the virus. So you still want to take some precautions. You're not off to the races anymore and don't have any kind of, responsibility there. But, I think I would advise doing some testing upon return just as a safeguard. And it's usually like CDC recently updated its guidelines, even for vaccinated people. So, certainly if you've been exposed to somebody with COVID, you want to get tested within like 3 to 5 days. And I would say, even if you're traveling, you might want to consider, getting tested 3 to 5 days upon return. And then, probably again, in another few days, just to rule out the possibility that you have been infected. Because that's, again, part of this layering of protections and how we're going to get a handle on this. I mean, it's unfortunately spreading so much that we don't really have, we never really achieved, the ability to do proper contact tracing. But I think have an abundance of caution and responsibility is the right thing to do.
Absolutely. And on the same lines of safety, so let's talk about those like screenings and doctor's appointments that maybe we didn't go to last year, that we're starting to do this year. First half of the question, how important is it for us to go in and have those things done? And secondly, how can we stay safe while we're there? One of the questions is while they're getting an MRI, how can they safely mask? What do you recommend for that? N95s have metal on them, so they're not an option.
No, I think the good news is that, healthcare facilities really became some of the safest places, I would say, during the pandemic, because they put in place rigorous protocols to intercept and separate people, segregate, people who are infected with COVID from the regular, patient population. People have to go in, they're masked, they have to, fever checks and all those kinds of things. The screening part, is critical. So because of delayed screenings and other routine preventive healthcare services, people put off those things last year, and it's already resulting in stage shifting, meaning that patients are getting diagnosed at later stages of disease when, an optimal outcome is less likely, unfortunately. And the UK is saying, based on some of its early data, that we can expect a 5% increase in lung cancer deaths over the next 5 years. So I cannot stress enough how important it is for people to maintain those screenings, whether it be if they're, meet the criteria for LDCT screening, their annual mammograms, their colonoscopies, all those things, because that is another insurance policy you have. For catching disease early, even for children. Children were missing routine immunizations and other, well checks and things. So, I want people to feel comfortable going and getting those services. And I would say, again, healthcare facilities, I think by and large, have put in place protocols to protect them.
Absolutely. And so one could wear a cloth mask in an MRI machine and feel like they're being safe.
Or you're going to have, surgical mask, or, so I think a lot of places, like at least in my own healthcare facility, when I've gone for my mammogram or, taking my kids for, a well visit or other needs that they may have, they asked you to swap out your cloth mask upon entry with a surgical mask. So they provided those while you were on site. So And my apologies. In that same spirit, I have to, and not long from now, take my daughter for her 12-year well check. So probably need to wrap up with the last couple of questions, but we can always do this again. So, I'm happy to do an encore performance as well if there are more questions.
Absolutely. There are always a ton of questions, and thank you for staying a little long to answer our questions. But I only have one more left as final words. Any final thoughts that you'd like to share with those listening in today?
I recognize it's a scary time. It's a time filled with anxiety. I want people to not lose hope. I want them to avail themselves of, evidence-based information. I want them to get vaccinated. I think, we're obviously deeply concerned about some of the things we're seeing going on in the country in places where, mortality is increasing, and I would say my colleague, our Chief Health Equity Officer, she's doing a lot around issues of health equity and how we can think about issues related to vaccine hesitancy or ensuring equal access to vaccines, because that's also an issue among communities of color. I'll be doing, for those who are interested, convening another webinar coming up later in September with Drs. Fred Hirsch, Paul Bunn, and Adolfo Garcia-Sastre, where we'll be reporting out on some of the data from World Lung, including some of our own work, sharing some of the ISLC did a survey on the impact of the pandemic on clinical trials, and Dr. Garcia-Sastre will give us kind of a more up-to-date account of where we are with vaccines and boosters. So for those who feel comfortable diving deeper into and
That's wonderful. I think that is something to look forward to, and we will post those links on how people can get connected. And we will follow up with an encore for sure. Thank you for everyone who joined in today. Thank you, Dr. Amy, for all of your time and attention. And if we did not get to your questions, we will try to answer them in a future webinar, in a meetup, or on a podcast. That said, thanks everybody for joining us. Stay safe and have a great night.
Bye, y'all.
Bye.
Thank you for tuning in to our podcast today. LUNGevity initiatives position us as thought leaders in the lung cancer advocacy community, providing programs and driving change for those with lung cancer today and in the future. Please visit our website at www.lungevity.org for more information and to stay connected to the lung cancer community. Our vision is a world where no one dies of lung cancer, and together we'll get there.